Hi, and welcome back to the WHY-O-MYO podcast. This is Janine Steen, your host, hoping to answer your questions about the who, what, where, when, why, and how when it comes to myofunctional therapy. Disclaimer. All content and details, as well as education shared on the podcast, are the opinions of the speaker and for informational purposes only. Please consult with a certified medical professional regarding any questions or concerns, as this podcast should not serve as a diagnosis or replace the information that you have received from a healthcare provider. I want to take this opportunity to talk a little bit about the controversy that has existed or that has been played out in the news and in the papers and online about frenectomies and the fact that they are being overdone and their goal is to generate revenue for the doctor. And I have to say, when hearing some of the feedback or some of the backlash that has occurred regarding frenectomies being done and the fact that they're being done unnecessarily or they're being overdone, or it is a money generating, income generating tool for medical and dental professionals to when they're performing frenectomies, it is insanely disheartening for me as a myofunctional therapist, as a speech pathologist, for my staff who are also trained as lactation consultants, as feeding therapists. My list goes on and on, especially because as speech pathologists, myofunctional therapists, we are often making the referral to this provider, this frenectomy provider, because of something we're seeing in a therapy setting. It is very seldom that an oral surgeon or a pediatrician is just randomly looking in patients' mouths when they come in. I mean, ultimately, you never go to an oral surgeon unless you need to be there. But if you're at your pediatrician or your pediatric dentist, there's very seldom a time, I believe, because especially having my own children, that they look in the mouth, they say, your frenum's short, you know what, schedule appointment, we're going to laser it, or we're going to cut it, or whatever we're going to do. Most of the time when we are looking at the frenum, and this is definitely something that it needs to change, and I believe we're working toward change. But the frenum should be looked at from the second that child is delivered, and right before or immediately following the mother's attempt or first experience with breastfeeding. Because if we're not looking at the frenum that early on, and again, who's looking at it? It's usually the lactation consultant in the hospital, the nurse in the nursery or in the NICU, the pediatrician when they come in to see the baby. If they're not looking at it and the mother goes home and she is having extreme difficulty with the baby latching, or she's in a lot of pain, or when the baby is nursing, or the baby is projectile vomiting, or or spitting up excessively, presenting with colic, or extremely gassy, the mom is always the one that's trying to make changes, whether it means changing their diet, eliminating things from their diet, making sure the baby is sitting up after they're eating, spacing out their feedings, trying, oh my goodness, it must be because I'm breastfeeding. Maybe I need to switch to a bottle, then trying a million different bottles. And if they're not breastfeeding, then is it the formula? And trying a million different types of formula. And ultimately, as a a mother, you feel ineffective. You feel like you're failing your child. I mean, this is my experience, of course, myself, and from speaking to so many mothers along the way. And it's hard enough to have a newborn and suffer through the hormones that exist post delivery and the sleep deprivation. But if you feel your child is suffering or not getting the nutrition they need from breastfeeding or while they are feeding, whether it be the breast or the bottle, it is insanely frustrating. But not only that, it is not common knowledge for a woman or a mother to say, "Let me take a peek at the piece of skin or the tension underneath the tongue, which is the lingual frenum, and see if that is too tight or too restricted." Or let me take a peek at their labial frenum underneath their lip, or any to see if there's any buccal ties in their cheeks, any tethered oral tissue. First of all, I don't even know if that's in a mom's vocabulary, generally speaking, but it's definitely not their first inclination to check that unless they've been told or they've experienced it in the past. I know I've mentioned before, but being tongue tied or having tethered oral tissue is often hereditary. However, it doesn't necessarily mean that if one baby has it, the next baby may have it, but it may not be affecting their diet or affecting their feeding or affecting their digestion. So it's not a one case fits all or one tethered tissue fits all. It's really contingent upon what the symptoms are that are going to potentially alert us that we need to address this shortened frenum. And so now, if we don't address it in the hospital or the parent is not told initially, then ultimately, after they struggle and try all these different things, and the only other provider now you're seeing at this time is your pediatrician. And when you go to the pediatrician, it is, I mean, at least it wasn't for me and for many of the mothers I've spoken to, it is not common to have for the pediatrician to automatically check the frenum, whether it be, and to check if there's any other tethered oral tissue, whether it be the lip, the tongue, the cheek. So when a mom is saying that her child's gassy or colicky or staying up or projectile vomiting or having difficulty latching, oftentimes the recommendation is we'll switch bottle or switch position or sit the child up, or let's give them Zantac, or let's try gripe water, or there's so many other things that are recommended. And at this point, if it wasn't identified in the hospital and your pediatrician is not looking at it, then who else is going to identify it? Now, if you're a parent that is really wants to breastfeed, and they're having all of these difficulties, sometimes they will bring in and reach out for the help of a lactation consultant. But again, that's not always available. It's not always something that a parent can or a mother can afford to do or has access to. And I want to believe that all lactation consultants would take a peek and make sure that there are no tethered oral tissues that could be negatively impacting this child's ability to feed. But it's very common for the pediatrician to say, "Oh no, they're gaining weight. They're not failure to thrive. This is, just keep trying, or let's switch to this formula, or let's eliminate dairy, and now." If that doesn't change, well, now we're putting our child through allergy testing, and let's check their stool, and let's see if there's something else going on. So now our only resource, if we left the hospital and no one identified it, and now we're seeing our pediatrician, again, we're not seeing a dentist until the child's older. So if the pediatrician's not identifying it, the practitioners in the hospital not identifying it, Well, now it's just on the mom to feel this absolute agony because their child is having difficulty feeding or latching, or the mom is getting extreme infections, mastitis, thrush, so many other things that are happening, and we're not seeing, they're not knowing why. And sometimes, I don't want to say it's as easy as, but so many times it is the result of a tethered oral tissue, and addressing that can make a difference. So going back to my original point, where we were talking about how practitioners are getting a bad name for overdoing frenectomies, those practitioners, whether it's usually either an oral surgeon, a pediatric dentist, or an ENT, you're not seeing any of those individuals at your child's young age unless there's something else going on, or because someone has referred you there. So, nobody is standing out on the corner, soliciting people to come over and open their mouth and say, let me see inside your mouth and let me see if your tongue is tied or you have a lip tie. It is usually the recommendation of another provider to see someone that can perform a frenectomy. I know personally for us, we will refer to, or in my practice, oral surgeon or a pediatric dentist. But we feel confident in those referrals, that we know that this is what we're seeing as speech pathologists, and these are the symptoms that are being reported, or these are the things we're observing. And based on that, we are sending our patient to an oral surgeon, a pediatric dentist, even sometimes an ENT, for their expert opinion, because it is their expertise, to tell us if they feel that tethered oral tissue, wherever it may be, is the reason that our patient is having these issues. Or as a mother, we're sending you there to see if the doctor is able to tell you that this is the reason your child is having all of these difficulties. And in the last 5 to 7 years, there has even been so much emphasis on not just referring these patients to a medical or dental provider for frenectomies, but many times the provider will not see the patient until the therapist is actively working to improve the mobility of the tongue, to start to work on that resting posture, that neuromuscular re-education, start working on not only teaching the child where their tongue needs to be, but training the parent on how to support that at home. And they will not even touch the child until that happens. And I will say, in our practice, when we're doing evaluations and we notice that a patient may have some type of tethered oral tissue, sometimes we don't make the recommendation right away to the medical or dental provider, because we want to tease out, is it an issue with mobility, or is it an issue with jaw grating or tongue jaw dissociation? And we'll say, in some regards, let's work on stretching the frenum. So ultimately, we're not stretching the frenum. What we're doing is working on tongue jaw dissociation. And by doing that, if we can effectively do that, it is sometimes unnecessary to go through with the frenectomy. However, after working with this patient for a period of times, usually 6 or 7 sessions, and again with home practice as well, then the patient is referred to this medical or dental provider for their expertise and opinion about whether a frenectomy is necessary. And again, as the person making the referral, as the provider making the referral, we're telling the doctor or the dentist, this is our concerns, this is what we've tried, this is what the patient is reporting, or this is what the parent is reporting. And these are the things that have been ineffective thus far. And we're looking to those providers to help us, to give us the ability to give that tongue the range of motion, so that we then can work on, after the frenectomy, improving tongue jaw dissociation, improving muscle memory, improving working towards neuromuscular re-education, because we can't just send our patient for a frenectomy and say, okay, they're done, there's no issue. Especially those patients that have frenectomies during infancy. Everything's really tiny in there, and there's not a lot of space. So it is not uncommon for a frenectomy to be done, and it to be done in a conservative manner, meaning that they're maybe not releasing as much as they would typically if it was an older child or an adult. And sometimes that means that later on down the road, when the patient is having issues with chewing or swallowing or tongue thrust, that the patient requires a revision procedure. And so that a little more can be released so that the tongue has more mobility and range of motion. But even beyond that, it is extremely important not only to have therapy before we have a frenectomy is completed, but the therapy after is so crucial, not only because if they're an infant, it's conservative and we want to get the maximum amount of movement of the tongue, but regardless of age, if we don't move it, you lose it, for a lack of a better word, meaning that it will adhere again to the bottom of the mouth. You won't get the full benefit of the frenectomy. And even though you released it, the tongue still doesn't know what it should be doing and where it should be going. So it just reverts back to its habit or what it's been doing or where it's been resting this entire time. And then, and unfortunately, nothing changes. So people will think like, oh, great, I had it done, things should improve. But we still have to retrain the tongue. We still have to teach it what it needs to be doing, where it should be resting, how it should be swallowing, where it needs to be if you're latching or articulating or speaking or swallowing, because that doesn't happen naturally. Like anything else, swallowing is a motor plan. So if we do it wrong for a period of time, it doesn't just automatically correct itself because we gave it more room to move. We have to reteach it. We have to show the tongue, this is what I need you to do now with all of this range of motion. And like I said from the beginning, it's very sad to me that there came a time where it was even challenged that any doctor or dentist would, or medical or dental provider would do this for the purposes of generating revenue, or that these were being overdone, because the majority of the time, those patients that are getting frenectomies are being referred by other medical or therapeutic providers because of the symptoms that are present, the multiple strategies or attempts they've tried at doing other things that have not worked. And like I said, they're not soliciting these patients. And it is really important. The sooner we can identify, intervene, and utilize therapy to support it, the better chance that the tethered oral tissue will have limited implications on things for the future, meaning it will start to have the proper positioning and range of motion for articulation, for swallowing, for resting posture, for maximizing airway space. So it's important that we continue to look at this as a team approach and always keep in mind that at the end of the day, our goal is to listen to our patient, to observe and utilize our professional background to make the recommendations or the referrals that we think are necessary and that are going to help our patients.
I hope I was able to give you some insight and answer some of your questions regarding myofunctional therapy. Please stay tuned and listen to our Myo Minute, and tune in to our Talk the Talk interviews with the many different medical, dental, and rehab professionals as they elaborate or answer your questions and address your concerns directly, especially when it's related to speech-language pathology and myofunctional therapy.